Good morning, everyone, and welcome to our monthly International Colorectal Web Meeting. Today, so far, we have pediatric surgeons and APPs joining from Saudi Arabia, Malaysia, Mexico, Macedonia, Austria, United States, Russia, Vietnam, Thailand, Indonesia, and Brazil. If I missed your country, please type in the chat, and then we'll acknowledge at the end. I see Algeria and Guyana, so welcome everyone. The first case today will be presented by Dr. Eliane Hefty, that is presenting from Instituto Nacional de Pediatría in Mexico City, Mexico. Welcome.
Good morning, everyone. And always, it is a pleasure to share with you today. I will be presenting the case of a patient whom operated a few months ago. I'm going to share the screen now. Okay. So this is a case of a 4-year-old female patient who was referred to us, to our institution, for an evaluation by the colorectal surgery department. The photos I am showing to you, we can see the genital region here and the abdomen area, and I will provide more details later. So with this information, I ask what is your initial diagnosis impression? So our first impression for us was that the patient had two muscular complexes with a Mullerian duplication, as we can see in this picture. So we expected, as we can know about the literature, that she will have a rectal duplication too. So at the first impression for us, the patient diagnosis at first were a complex anorectal malformation. Here we can see a rectovestibular fistula of the left complex. We can see here the right complex is here and the left complex is here. We have a caudal duplication syndrome with a complete double urinary tract due to the lack of cervical fusion with Mullerian duplication. We have also a diastasis of the pubic symphysis, as you can see at the first picture, and a sacral hypoplasia that I'm going to show you later in the X-ray, and a grade 3 right vesico-retroral reflux. This diagnosis, we had it based on a control study from another hospital, but we didn't have the images for this presentation. At the physical examination, we found, the two complexes. In the right complex, we can see here in the picture, but we had a vagina, an urethra, and a clitoris. And in the left complex, as we can see here, we have a vagina also, a rectovestibular fistula, and a urethra here, and the clitoris. And we asked to the mother directed questioning, and the mother reported that the patient is urinary continent through both urethras, for both of the urethras of the complexes. So she had a colostomy when she was born on the first day. And at 8 months of life, she had a uretrocystoscopy and a vaginoscopy. That was performed at another hospital, so we don't have the images available. So the findings included that she had two complexes, each with its respective urethras, vaginas, and a cervix. The right one has 3.5 centimeters of length, and she has a cervix. And in the left duplication, they reported a vagina of 3.5 centimeters of length. So we made all the diagnosis approach. We sent the patient to cardiology, and they didn't found any cardiac pathology. We also sent it to orthopedics, and they told us that the patient is a candidate for surgical treatment, but she needs more studies. And the urology team, they asked them to have a renal bladder ultrasound and other studies to evaluate the renal function. So I'm gonna put you these videos. This is an abdominal and renal video. So we can find in these two. I'm gonna put you the two. So we can find here, we found it that we have a bladder duplication with two separate cavities divided by a thin, well-defined wall, and a single cervical canal measuring approximately to 33 millimeters. And we had a diastasis of the rectus muscles. So here in the left image, you can see a thin wall here that can divide the two bladders. And in the right image, we can see the pelvic X-ray and shows a sacral index of 0.39 that we know that is a poor prognosis sacral index. And we can see that the sacrum is really hypoplastic. So with this physical examination and the studies we have so far, what would be your surgical plan? Well, for us, we discussed the case with the urology department, and it was decided to perform a cystoscopy first, well, in the same surgical time, and this to evaluate both urethras and the bladders, and also the vagina, so we can determine which complex should remain functional, and then to proceed with the correction for the vestibular fistula. It's important to say that we evaluate the function, the renal function, and it was okay. So that's why we proceed to this. So as a preparative preparation, we had a standard antimicrobial protocol. With metronidazole and cefixime, 48 hours preparative. And then the hospital admission is 24 hours prior to surgery and a fasting of 8 hours before the procedure. So this is the images from the OR. We can see here, well, the colostomy. We can see here the part of, I told you about the rectum diastasis. Both complexes, the right one and the left one. We saw in the first consult that we had with the patient that the left complex, it was better than the right complex. So the plan was to use this one. And we can see here, this image is really clear. We can see here the vagina, the fistula was here, and the urethra, we can see it here. So the first thing that we made, well, it was by the urology team. They made the cystoscopy, diagnosis cystoscopy. So here I'm gonna put you the first video. We don't have all the images, but we can see here that here's the vagina, and it was on the first vagina is the right complex of 3 centimeters length. That is according to the first report of the cystoscopy, and we can see the cervix here. And the left complex, we don't have the image of the vagina and the cervix, but it also have one vagina, 4 centimeters length, and one cervix. But we can see the bladder here, it was better than the right one. So, and it was better, the bladder neck, it has like more structure. So at the end of the cystoscopy, both ureters were catheterized with a 10 French Foley catheter. You can see here all the both ureters, and here's the vagina of the right complex that we didn't see in the other pictures. So then we placed the patient in prone position, and the surgical side was cleansed here, all the area. And we started with a sagittal posterior approach using electrostimulation. We identified the the muscular complex, and we saw that we were right, the left complex was better. So the dissection was performed in layers until reaching the posterior fascia of the rectum as a normal approaching. And the circumferential traction sutures were placed around the fistula, as we can see here in the picture. And I'm gonna put you this video. So while we were dissecting the walls of the rectum, the anterior and the lateral surfaces, always careful separating it from the posterior vaginal wall to avoid injury. And when we found that a blind ending pararectal segment was identified on the left side, as we can see in the video, and it was containing abundant mucus and consistent with a rectal duplication. So I'm gonna put you again the video. So you can see there. And it was a blind segment there. So this segment was, I think there's another video. This segment was measured, and it was 9 centimeters in length and had no communication with the rectum, so it was blindfolding. So we put silk traction sutures circumferentially, and as you can see here, there is the rectal duplication, and here is the rectum. So we made a septoptomy to create communication between the both rectal cavities using a 16 millimeters linear stapler, as you can see here. So in this picture, you can see that both cavities are communicated now. And once rectal patency was confirmed, we proceeded to the perineal and posterior sagittal reconstruction, followed by the anaplasty. So in the postoperative evolution, the course was uneventful and followed protocol, and then rectal dilations were initiated where, sorry, 2 weeks postoperatively, and the patient is currently now at Hagar size 16. Follow-up continues with the urology team, orthopedics, and genetics for further evaluation and surgical planning. So our conclusions is that multidisciplinary management is essential, as these patients often have complex colorectal and urogenital malformations, and they requiring coordination with other specialties. It's really important renal function must always be assessed and prioritized to prevent long-term complications such as renal damage. And in this particular case, evaluating the function of the muscle complex was crucial for anatomical and functional reconstruction, especially regarding continence for this patient. We expected to have a rectal segment for each of the complexes that I mentioned at the first slide, but in this case, we only had one rectal segment with a duplication that wasn't communicated. So that concludes our presentation. Thank you very much. I hope you enjoyed this. And if anyone has any question or comments, feel free to ask.
Thank you very much. I think those cases are always fascinating because one is never exactly the same as the other. So, my first question is, did you do an MRI of the patient to look at the spine and to look at the perineum to see if in between the duplication, what you have is fat or what it is?
Yeah, she had an MRI from the other hospital. We didn't have the images, only the report. So the report said that the spine was okay, and they only reported that she had one vagina, and but we didn't have the images, so we don't know for sure that.
Okay. So I think for these patients, it's very important to have an MRI. Many of them have neural tube defects. So they either have a lipomeningocele or a
Mhm.
lipomyelomeningocele. I don't know, she may have, but it's also important to know what's in the perineum because for the future reconstruction, if what is in the perineum is just fat, that's something that sometimes plastic surgery can remove the fat and then you're able to bring together the vaginas. I think the only other important comment is that this patient has a very poor sacrum, 0.39. So we don't expect bowel control. The other thing that I was very surprised is the fact that she has urinary control because usually when you have a very separated pubic bone in a normal case, not in a duplicated case, you don't have bladder neck. So patients just leak urine constant. In a duplicated case, I'm going to say I don't know, but I will be surprised if this patient indeed has urinary control. If she does, for patients that we have seen that have duplicated bladder, duplicated urethra, yes, they can have urinary control. In this case, I am not sure, but if she has, great. The only thing that it's unclear to me is why orthopedic is proposing the pubic bone fusion. Because we believe in the benefit of the pubic bone fusion in cases, for example, of bladder extrophy, in which you need that help just to close the abdomen. In this case, I really don't see what they are proposing as the benefit because for walking, for I honestly don't know why they would propose the fusion of the pubic bone.
Well, in this case, Dr. Andrea, I also have a question for this, but yeah, the patient had this like for walking, she was walking a little bit asymmetrical. So
Uh-huh.
here I'm gonna show you this picture. Here she has a bit separated the pubis. So I have a question for you and Dr. Peña. Given these characteristics of the symphysis of the pubis, that I don't know if also corresponds to a spectrum of covered sewer extrophy, or what do you think about this?
Yes. So we consider those cases complex malformations just
Yeah,
because it's very hard to classify them on
yeah.
that. Because she has two bladders, I would be interested in studying her entire colon. If she has normal colon, two bladders, I would not put her in the spectrum of extrophy. I would put her in complex anomaly, duplication, caudal duplication. But I honestly don't see the benefit of closing the symphysis because in all cases in which they close in the later x-ray, you will see that it's separated again. So I think for ambulation, it does not improve. So I would just voice my concern that I don't see the benefit of closing in a patient like that. Do you want to comment?
Yeah. Not only, not only I don't think that trying to close the pubis would benefit her. I bet that would be impossible. You see the X-ray. There is an X-ray that you show. Show it again.
That one.
to see the separation of the pubic bones.
It's huge.
And it's really, it's just a utopia to think that you can bring that together and could have secondary bad effects. So I would not touch that. But that's my suggestion. And the other thing I saw in the questions that somebody asked, they say, is there a diagram of the malformation? And that's a very good question. When you present, this is an observation. When you present complex cases for all those surgeons who are listening, for you, the anatomy of the patient is very clear because you have been following the patient, because you operate, because you. But for the audience, is never clear in dealing with complex malformation. So when you present the case, you present the X-rays and then the endoscopy and so forth. At the end of all that evaluation, would be very, very valuable to make a diagram, not artistic, but rather schematic that shows exactly what's the summary of the malformation, to show the two rectums, the two vaginas, the exact everything that is there. So, and I'm also very surprised that see this patient has urinary control. If the patient has urinary control and no reflux, then don't touch the urinary tract. That's my suggestion, because it takes time to learn what we should do with patients, but it takes longer time to learn what we should not do with the patients. So again, if the patient has urinary control, no urinary tract infections, and no reflux, don't touch the urinary tract. And if the patient is walking, don't try to approximate the pubis, because first of all, will not be possible to do that. And if it happens and you achieve, the orthopedic surgeons finally achieve to bring the pubic together in stable conditions, please communicate that, because that would be a miracle.
Thank you for your comments, Dr. Pañan, Dr. Andrea. Yeah, the girl is urinary control for both urethras. The mom told us. That was surprising too for us. Yeah, the problem here is that she had reflux, urinary reflux from the right kidney. So that's why the urology team wanted to do some exams first, and then they're gonna decide what's gonna be the surgical plan for her. Is it better or it's worse? But the renal function is okay now, so that's why they have to do more studies, and then they will decide about it. And I'm gonna do the next time. I'm gonna do the diagram.
Perfect. Thank you so much. It's a very, very interesting case, and congratulations on the beautiful operation.
Thank you very much. And
so now we're going to move to the second case that is going to be presented by our colorectal fellow, Dr. Lauren Evans.
Okay. Good morning, everybody. So we have a case of an anal rectal malformation in a female. She presented as a full-term 4-kilogram infant that was transferred from an outside hospital after being found to have no anus on exam. When she got here, we placed an orogastric tube for decompression, kept her NPO, and started her on parenteral nutrition. So based on this, what studies would you like to order?
A few seconds for people to answer.
Fabulous. Yeah, it seems like everybody really got it. So with anal rectal malformations, you obviously want to do the whole Vactrol workup. And so really all of these studies are necessary before proceeding. So she got sacral x-rays, both AP and lateral, and had a normal sacral ratio. She also got ultrasounds of the kidneys, which also was demonstrated to be normal, and a spinal ultrasound that did not show any evidence of a neural tube defect or tethered cord. And an echo that just demonstrated a small PDA. and nothing of any kind of hemodynamic significance. At 24 hours, we did get another x-ray, and it demonstrated this. And based on that x-ray, do you guys think she would be a good candidate for a primary PSARP? What additional workup could aid in that decision in deciding whether or not to do a primary pull-through or a divided colostomy?
This is a long poll, so we'll give people a few seconds to answer.
Sure. Okay, we have a little bit of a split. Interesting. So we went ahead and got what we would call an invertogram, or a lateral film, to try to evaluate the position of the rectum and its distance from the perineum. And so based on this film, what would people do? Would you proceed with a primary PSARP, or would you wait? Or no, I'm sorry, not wait, but proceed with colostomies. Fabulous, we agree. So when you look at the invertogram, you can see that there's a 4 centimeter distance from the rectum to the skin. And usually our cutoff is around 1 centimeter that we would proceed with a primary PSARP. So she underwent a laparoscopic divided colostomy and mucus fistula at the descending colon, and they were able to irrigate a moderate amount of meconium from the mucus fistula. So from there, on day of life 5, she was found to have a large meconium stool from her vagina. And based on that, she had a presumed diagnosis of a rectovaginal versus a rectovestibular fistula. She was ultimately discharged home on day of life 7 with plan for a distal colostogram at 6 weeks and a PSARP around 10 weeks of age. So this is her distal colostogram. I'm going to give everybody a second to have a look at it. Okay, so based on that distal colostogram, what is the diagnosis? And if we have I can put the images back up for everybody as well. Okay, so our radiologist agreed. So based on that distal colostogram, she was diagnosed with a rectovaginal fistula. You can see here the vagina filling on that contrast study. And so based off of that, sorry about that, she ultimately went to the operating room for a planned PSARP. However, at the initial part of the case, they had a difficult time placing the Foley. It took over 45 minutes. And we ultimately got called to the operating room in consultation for further evaluation. So that's kind of an interesting finding. Do you have any concerns before proceeding as planned based on the difficulty with placing the Foley? Okay, most of us agree as well. So our concern was that rectovaginal fistulas are exceedingly rare and that there's definitely concern for a misdiagnosis here. So in the operating room, we did an exam under anesthesia, which demonstrated a cloaca type 1 with a very short common channel. On exam, you could actually see the urethral orifice from the common channel. We performed a cystoscopy and vaginoscopy at that time, which demonstrated a 1 centimeter common channel, a native vagina with a single cervix, and a normal urethra and normal bladder neck. Ultimately, her planned PSARP was canceled with plan for a multidisciplinary follow-up in clinic and repair at a later date. So at around 4 months old, she then went back to the operating room for a planned PSAR VUP. We repeated the cystoscopy and vaginoscopy, which again demonstrated a short common channel that was about 1 centimeter to the bifurcation of the urethra and vagina, and about 3 centimeters to the takeoff of the rectum. She did have a single vagina that was about 7 centimeters in length, and you can see here that she had a single cervix, but that was septated down the midline, which suggests that she also has a septated uterus. She otherwise had, again, normal urinary tract anatomy that was demonstrated. So based on these findings, what would your preferred operative approach be? A posterior sagittal approach only, or plan for total body preparation because a laparotomy is likely needed with a combination posterior sagittal approach? Okay, so because of the short common channel and the distance of the anatomy to the perineum, we were able to proceed with a posterior sagittal approach only. So we started with a PSARP incision. We delineated the anatomy of the entire common channel and clearly identified the rectum, vagina, and urethra. You can see the common channel here, and you can start to see the posterior fascia of the rectum here. And we had urology place a Foley. We then opened the distal rectum by placing 5-0 silk sutures circumferentially to apply uniform traction to the rectum once it was opened. We then proceeded to delineate the lateral rectal walls to facilitate a better anterior dissection. And then we fully separated the vagina from the rectum. And you can see here where that plane starts to show itself on the anterior side. So then we completed the anterior dissection until the rectum and vagina were distinct and separate structures. We mobilized the proximal rectum to ensure we had a tension-free anaplasty. We required minimal mobilization of the posterior wall of the vagina, so we were able to proceed with a vaginoplasty without having to do a total urogenital mobilization. We then proceeded by marking the limits of the sphincter and then reconstructed the perineal body. After that reconstruction, the vaginal wall looked well perfused and there was no tension on the vaginoplasty. So we then proceeded with the anoplasty, applied sutures from posterior edge of the muscle complex into the back wall of the rectum to ensure that the rectum laid within the sphincter mechanism that we had marked out. We proceeded to close the posterior sagittal incision in layers and then performed our anoplasty in 2 layers, placing deep sutures in 4 quadrants. We then trimmed the distal rectum about 3 millimeters on each side, and then completed the superficial layers of the layer of the anoplasty with 5-0 and 6-0 vicryls. The anoplasty was intentionally performed under a little bit of tension so that the anus retracted after the sutures were cut, and we had no evidence of prolapse. And her post-operative care will be bacitracin for 5 days along the incision. She'll be double diapered for a month. The Foley came out after a day, given that we did not perform any urethroplasty. And the plan will be a follow-up appointment 2 weeks post-operatively to start dilations, with plan to do dilations twice daily and increase each size of the Hagar every week. And then she will be a candidate for colostomy closure when she reaches her final dilator size, which is typically about 4 to 6 weeks after starting dilations.
Thank you very much, Dr. Evans. I think everybody is asking, can a cloaca be diagnosed during the newborn exam? So can you answer that?
Yes, with an external exam and just one perineal orifice, you can definitely diagnose a cloaca as a newborn.
Perfect. And as Lauren mentioned, rectovaginal fistula or no fistula are rare diagnoses. So in females, our mind should be, is this a rectoperineal? Is this a rectovestibular? Or is this a cloaca? And with a good physical exam, we should be able to differentiate those. And it's very unsettling for the family to have to cancel a procedure or to find out that now she has a different diagnosis. So it's on us to do a very good physical exam before we plan for an operation. You want to comment?
Yes, well, number one, congratulations, a beautiful case. I must say that this is the kind of case that every pediatric surgeon in the world is looking for, because the paradigm, the ideal case in pediatric surgery is one that a patient that has a malformation, they that we can repair and have excellent results. When this kind of case is operated with adequate technique, the patient is going to have urinary control, bowel control, sexual function, and that's what gives us pediatric surgeons great satisfaction. You charge our emotional batteries after an operation of this, and seeing the patient growing and seeing a happy patient. Unfortunately, not all the cases are born like this. The other thing that I usually like to repeat is that our mind, our eyes only see what our mind suspects. So this malformation was not suspected because the baby was not examined properly at birth. The adequate clinical examination would save the baby a lot of other problems. Congratulations.
Any other questions? So I'm gonna share my screen now. Oops, 1 second. I thought I had my presentation here. Let me just find my presentation. Give me 1 second. Okay, now let me share my presentation. Can you see just one slide?
Yes, perfect.
Perfect. Okay, so I have two simple cases. So the first one is an 8-month-old male patient that had constipation since 2 weeks of life. With this history, what would you like to do? A rectal biopsy and a contrast enema, a physical exam, a manometry, or I don't know. Everybody can vote. And let's see the results. Very interesting. I think the message of the meeting today will be to remind everyone about the importance of physical exam. That's exactly what Dr. Evans just showed, that the diagnosis was missed. So in this case, I'll show you what is the diagnosis. So the most important thing here is to do a physical exam. So this is whenever we see a patient in clinic, our patients get abdominal x-ray because we want to see how constipated they truly are. So this is the abdominal x-ray, and you can see that the patient is very constipated. And that's the physical exam. So we are looking at the bottom, and we are seeing this tiny hole here. So for those that said contrast enema and rectal biopsy, I would say this would be very challenging. So now that you have seen the perineum, what studies would you like to order? Spinal X-ray, spinal ultrasound, spinal and pelvic MRI, contrast enema, kidney ultrasound, 4 of the above. Everybody can vote. Okay. So the reason why we said we have to do the entire screening for anorectal malformation, but the key for this question is just to remind everyone that the spinal ultrasound to rule out tetrachord can only be done before 3 months of age. After 3 months of age, you have to get an MRI because of the ossification. So in this case, we got spinal X-ray, we got sacral X-ray, AP and lateral, spinal and pelvis MRI, contrast enema, and kidney ultrasound. So now let's see the results. So this is the sacrum. So if we do the sacral ratio here, you can see that the patient has a very good sacrum, a normal sacrum. That's the contrast enema. And remember, this is an 8-month-old baby. So it's not surprising that the rectal sigmoid is dilated because he is already eating and he has been suffering passing that stool from that tiny hole for a long time. So that's the contrast enema. That's the kidney ultrasound. You can see he has normal kidneys. That's the MRI showing that there is no tetrachord and no presacral mass. So now the patient is in prone position and we are gonna do the operation. And the reason why I brought this case is because if you use the electrical stimulator, you will see that this is where the anus should be located. So the opening was at the spot, but anterior. So I thought this was a good case to only mobilize the posterior rectal wall. That's not in all cases of rectoperineal fistula. In many of them, they are outside the sphincter, but in this case, it was within the sphincter. So we placed those sutures as our landmark of what we didn't want to touch, the anterior hemicircumference. We placed multiple 5-0 stitches at the posterior hemicircumference. We opened, dissected the posterior and lateral walls, and then we did an anoplasty without mobilizing this anterior edge. So this is the final aspect. And I will also want to emphasize the importance of following those patients. So number one, we always do anal dilations, especially in cases for good prognosis, that when we cut the sutures, the anus is closed. If we let it heal like that, it will heal narrow. So we started anal dilations, but you can see that we send the patient from the hospital without laxatives. But on the 11th-day post-op, you can see the patient is already showing signs of severe constipation. So in clinic, I did a Pedialex, that it's a liquid glycerin suppository. The patient had a massive bowel movement, and we started the patient on Senna. It's very important to tell families preoperatively that the operation will not fix the constipation. The patient will still be constipated. Of course, it will be easier for him to stool from that tiny hole to an adequate size, but the constipation will persist. So that's why it's important to follow those patients and make sure they are in a good laxative regimen. So this is just 11 days after surgery. Remember that for 7 days, the patient was NPO on TPN, and the patient had a completely clean bowel. So this accumulated in over a very short period of time. You want to comment?
Yes. I was surprised to see that Dr. Bishop discharged the patient without laxatives because I keep saying that the good news to give to the family, your baby was born with a benign malformation. Your baby is going to live 90 years and it's going to have bowel control and urinary control and sexual function. But the bad news is that the baby will suffer constipation for life. Now, this is difficult to accept from the families because the families are very much against the use of laxatives, because you can hear everybody saying that if you start taking laxatives, you become laxative dependent. And I keep explaining to the family, it's not that we want to make your son laxative dependent. It's that your baby was born with a condition that makes him laxative dependent. With the operation, we released the mechanical obstruction, but we did not fix the dysmotility of the rectum that the baby was born with. So the baby will need laxative for life and must be followed closely, because we still have to determine the right amount of laxative for the patient and be ready perhaps even to increase the amount of laxative as the patient keeps growing. So keep that in mind, because we see many patients that had a correct operation, but then they develop a huge giant megacolon. It becomes very complicated. So yes, the mechanical obstruction now is released, but the patient has a primary dysmotility problem in the rectosigmoid.
Yeah, so the only reason why I didn't send the patient home with laxatives was because sometimes when we have a tiny hole and then you make an adequate hole, it's almost the relief of an obstruction. So the patient stools a lot and they get bad diaper rash. So, and I was going to see the patient 3 days after. So that's the only reason why I didn't send, which in retrospect was a mistake. And I always send the patients with my cell phone and I tell them, if there is no bowel movement in 24 hours, this is a problem. And most patients call me. And this one, the mom said, oh, he has not stooled in the past 2 days. And I said, why didn't you call me? And she said, I didn't want to bother you. So I think this definitely needed laxatives in retrospect, but now he's being followed and will manage the constipation appropriately. Any questions? Let me see. I cannot see the chat. Is there any questions? Said this come with severe perianal scoriation, but this one has a healthy skin. Well, in patients with rectoperineal fistula that have a late diagnosis, I don't see severe scoriation because they suffer from severe constipation. So that has been my experience. I think that's the only questions that we see. So we're going to move to the next case. So this was a 2 days old male patient that was transferred to the NICU for concerns of bowel obstruction. Sorry for the mistake. So whenever a newborn comes with concern of obstruction in the United States, the first study that they get is an upper GI to rule out malrotation in volvulus. But you can see on this image that there is dilations of bowel. So they did an upper GI and it was read as inconclusive because they could not see the duodenum doing the full curve and moving to the other side. So they did a contrast enema and I thought this image was really beautiful because it's almost like you're seeing a transition zone, but then when they continue to feel, you still see some differences in caliber. But here you can see the difference between 1.9 centimeters and 2.9 centimeters. Now, those are the later films, and you can see that the baby is distended, and apparently there is a difference in caliber between the rectum and the left colon. So with these studies, what do you suspect? A midgut volvulus, Hirschsprung disease, meconium plug, or I don't know. And the majority said Hirschsprung disease. And it's okay to say I don't know because I don't think every case is crystal clear. So the patient underwent exploratory laparotomy and creation of an ileostomy with mucus fistula. At the same anesthesia, he underwent transanal suction biopsy. The findings were normal position of the ligament of Treitz, no evidence of intestinal atresia, no evidence of meconium disease, but no clear transition zone. The biopsy results came back as no ganglion cells and hypertrophic nerves.
Where?
In the rectum.
What about the rapid colon?
Was not biopsied. So patient underwent a laparoscopic assisted Suave pull-through at 7 months of age. And at that time, 29 centimeters of colon, which was the rectal sigmoid, was resected. And he had approximately 10 centimeters of aganglionosis, then a little bit of transition zone. He was planned for ileostomy closure at 8 months of age. Let me move the, oh, I can't see the question. During rectal examination, he was found to have a severe stricture. So what would you do now? close the ileostomy and recommend anal dilations, abort the ileostomy closure and recommend anal dilations, study the patient and plan for reoperation. Can you see the poll? I don't know if I closed. Wow, we have everywhere. Some people said close the ileostomy and recommend anal dilations. I would not do this approach because if you have detected that you have severe stricture, you have to be cautioned. Abort the ileostomy closure and recommend anal dilations. Study the patient and plan for reoperation. So it's very important to remember that in anorectal malformation and Hirschsprung disease, anal dilations are not to dilate severe real stricture. That's not the purpose of anal dilations. Anal dilations are just to avoid the natural healing process from healing and narrowing our surgery. If you have detected a severe stricture, don't submit the patient into dilations because this is torture. Families do suffer, and that's why we have so much mixed feelings about dilations because of those cases in which the patient had true stricture and the surgeon asked the family to do dilations. So in this case, the surgeon smartly stopped the procedure and sent the patient to us. So we confirmed that the patient had a severe stricture and we ordered a distal ileostogram to evaluate the colon. We need to know how much colon do we have. And here we could see that we had the transverse, the descending colon, and that's where the level of the stricture was. So the patient had an intact anal canal and the stricture was at the anastomotic site. So then we advanced the hooks and this would not pass my little finger. And you can see there is fibrosis and it was a severe stricture. But it was just at the line of anastomosis. So we were able to place multiple 5-0 silks, and after a dissection of approximately 4 centimeters, we were very happy with how the tissue looked. We confirmed with a biopsy that we had ganglion cells and no hypertrophic nerves, and we did a new anastomosis. So this is the segment that we are resecting, and this is just to show you that we have protected the anal canal, that it's inside the hooks in here. Unfortunately, I didn't take a picture of the next anastomosis. That was just a resection. But the patient has been seen on post-op follow-up. We started anal dilations proactively. We did a digital exam. It feels good, but we don't want that segment to narrow. And we'll plan for ileostomy closure once the patient reaches the final Hager dilator size. That's what I had. Any questions about this case in which you need reoperations? Do you want to comment?
Well, so did I understand the original operation was done in another institution?
Correct.
So, and the question is why the patient developed that stricture. And it could be strictures come from as a consequence of ischemia. Perhaps he was underestimated the blood supply of the pull-through bowel. But what we do normally in patients with Hirschsprung disease is that they come to the clinic 1 month after they put through, and we pass our little finger just to feel, just to have a feeling of the anastomosis. And if you perceive that it's forming a ring, a fibrous ring, then we instruct the mother how to do dilatations. We don't do dilatation routinely in all the patients post put through Hirschsprung because the area of the anastomosis is deep inside the rectum. So the dilatations are rather blind, and we don't want to risk a perforation. If we pass our little finger and feel no evidence of a ring, the patient doesn't need dilatations. If we feel a ring, then we start instructing the mother with dilatations, before that becomes a real stricture, a fibrous stricture that, as Dr. Bishop said, should not be attempted. We should not attempt to dilate a real stricture because it's useless and it's painful and it's dangerous.
So I don't see any other questions. So I would like to thank everyone for joining us today. Again, today we had pediatric surgeons from Saudi Arabia, Malaysia, Mexico, Macedonia, Austria, United States, Russia, Vietnam, Thailand, Indonesia, Brazil, Algeria, Tanzania, Qatar, Guyana, Libya, Bahrain, Nigeria, and Chile. Those are the countries that I could get. Mozambique. I always miss a few. So thank you very much. We hope you can join us. Please send your cases. As you can see, every case is interesting. It can be a difficult one. It can be an easy one. We can always learn from them. So please send us cases so it's not always us presenting. We love to see cases from all over the world. And we hope to see you next time. Have a good weekend. Bye-bye.